course, it is the lab exam. So remember, if you are a Wednesday person, you go up to the hall and you wait outside in the hall. Tomorrow morning at 9 a.m., you go and wait in the hall. Okay? So that's the drill. Midterms, of course, came out this morning, or maybe last night, I don't know. She asked me to have everything submitted by 11:59. I had no idea when you guys see them. And basically, if you're paying attention, it was your grade on campus. Slapped it in there. That is taking nothing away. That is not adding anything. It is what it is. So if you do not have assignments in, that lowered your grade. Okay? Plain and simple. All right, so that's how that grade was calculated, just to keep you, to help you be aware. All right. So today we're still on the joints. Today we're going to look at not that one, this one, movements of synovial joints. Okay, so that's where we're going to be focusing a little bit today. And as I mentioned, because it's a lab day, right after this, we'll be out a little early. Give everybody a chance to relax. Okay. All right. There is also going to be a study session tonight for those of you who are taking the exam tomorrow. Okay. So I'll check on the time and get that on. All right. So we talked a lot about this idea of classification. We said there were two ways we classify joints. We could do it on movement, and we could do it based on structure. And this was combining those two to say synovial joints, okay, the ones that are with synovial capsules and with synovial fluid and synovial membranes. Those are what we consider to be diarthrotic in terms of movement, meaning freely movable, or antiarthrotic, partial movement. That was in contrast to the ones that are fibrous, like the interosseous membranes, that are anti or syn, where there is no movement. In fact, usually we don't want movement, like between the tibia and the fibula. And then lastly was cartilaginous. That is the structure, cartilage holding the bones together. Again, anti or syn arthrotic. And remember that an epiphyseal plate is a cartilaginous joint. So it is a true statement that before you are finished growing, you had more joints than you do now. Wow, that sounds like a great testimony. All right, so there's our, everybody's writing it down? Okay. So there's the synovial joint. Okay, so there again, remember a synovial capsule. That's the fibrous material that surrounds it. There's the synovial membrane on the inside that is producing the synovial fluid, which is a filtrate of plasma. When I say plasma, we are meaning there are no cells. Okay, there's no red blood cells or white blood cells. Absolutely no bacteria. That's really bad. And other cell types should not be present. And we notice that the epiphyses are covered by articular cartilage, which is hyaline. Those are all the requirements, okay, in order to define a synovial joint. But there are exterior things, or not exterior, accessories that are not included in a basic synovial joint. And those include ligaments that are found either inside or outside of the capsule. There are meniscuses. Menisci is the actual or correct way to say that. And there we go, bursa sacs or tendon sheets, additional synovial fluid to help the joint move smoothly. And a cushion there. Okay? So those are the additives, those are the accessories. And then, there we go, we talked about the classes of synovial joints. And as we mentioned, if you're a little bit into engineering, there you go, ball and socket. And that's exactly what it would look like to replace a ball and socket joint. Or the hinge. Now, we don't really replace elbows, but we could if we needed to. I think there are some actual hinge joint replacements out there, just not very frequently done. Pivot joints and saddle joints, those don't usually get replaced, although, again, you can do a saddle joint if you needed to. I'm not sure what purpose. I guess it might be. But that's not frequently done. And then we have the gliding and the condyloid. Okay, so those are the 6 categories or classes of synovial joints. So today we're going to look at how these all move. So what the intent is to describe a few of the movements, not necessarily what joints they're limited to, hinge or ball and socket, etc. That's not the intent. The intent is to say this is a movement. And on the exam, I will ask you if you do something, whatever that may be, what is that movement? Okay? So if you were to high step, what have you done with your knee? That's the kind of question that I might ask you. Does that make sense? So just kind of sit back, reflect on these, look through the PowerPoint when you have time before the exam to make sure you know what does it mean to do flexion and extension. So when we say the term flexion, you'll notice that one of the prime ways to demonstrate it is to use the humerus and the radius in the ulna. At the elbow, flexion means to decrease the angle. So you've gone from 180 degrees to 90 degrees. You have flexed your forearm. Okay? You can also see you can do it at the wrist. Okay? And, of course, with the entire upper extremity at the shoulder. That's flexion and extension. And then again at the knee. So extension is to return the part of the appendage to its existing or original position. And it is to increase the angle. So if you bent your wrist at 90, then you are going back to 180. Okay? Now, in some cases, as you can see, we can do hyperextension. That is to go past that original holding position. And the same would be true of the wrist, right? Okay. You really can't hyperextend your elbow because of the mechanical structural limitation. Now, I know there are some people in here who can, make a bow out of it, and I get it, but technically that's not really supposed to happen. Now, if your elbow's down on the ground, or your hand's down on the ground, and somebody hits it from the back, and you go, whoa, look at my arm, that'll freak me out. That happened. So, it's not supposed to do that, okay? Then we have abduction and adduction. Later on, when we start doing muscles, we are going to name muscles as adductors. That's part of their name. And adduction means to, as the name implies, add to the midline. Add it towards the midline. So your upper extremity is being added as you bring it down to stand at attention. Or if you are doing jumping jacks, when your leg goes out, that's abduction. When it comes back in, it is adduction. So to abduct, as that name says, abduct, you take away. All right? We're not kidnapping, but we're just taking it away to abduct. Okay? The upper and lower extremities are the classics, but guess what? What do you do with your fingers? These are in the adducted position. But then when I do that, then I have abducted my fingers because they moved away from the midline. Okay? Teach your kids. See how old the kid can be, has to be before they can do that. 2-year-olds can't do that. Okay? To abduct just those. Like that. They certainly can't do that. Okay? It's kind of fun. It's a learned thing. You have to develop the ability. Okay? All right, then we have elevation and depression. I don't know. What is elevation? I don't know. All right? I don't know. I have no idea what elevation is. Elevation, all right?
depression. Right? Just think of, when people are down, things are down, like their shoulder, depressed. Okay? So elevation and depression. And then we have protraction and retraction. All right? So you're pushing something away, you are protracting. Okay? Offensive lineman. Okay? They help you. So protraction versus retraction, pull back. Right? First step in the chicken dance. You gotta pull back on the shoulders. Okay? You're gonna do it right. So protraction, retraction. Then there's circumduction. Circumduction. Create a circle. Circumference with your upper extremity. We're doing this at the shoulder. The ball and socket of the shoulder is capable of doing that. Now you might immediately say, but what about the hip? No, it can't do it. It's different. It's moving at angles. It doesn't swing in a complete circle. The way, I know, that hurts on me. The way the upper extremity can do that. Then we have what is called medial rotation and lateral rotation. You see, my dancers are already starting to think about choreography and including all these things and telling their dancers, I need a little medial rotation. No? No, okay. All right. Well, all the students that are exercise science who have to take kinesiology, y'all need to know how to do these things, and you have to demonstrate them, and you have to know the muscles that do them. Okay? So, cueing those people up. Now, if you're nursing, you're not going to tell somebody, I need you to medially rotate while I put the sling on. You're just going to tell them, put your arm here, right? But you know that they medially rotated so you can put the sling on. Okay? Just different ways to think. So medial rotation towards the inside, internal. So to turn your foot, pigeon-toed, oh dear, that hurts. That is internal rotation. External rotation, walk like a duck, right? That's external rotation. I run that way. I'm a definite externally rotated person when I walk and run. Okay? You can see it in my footprints. I have landing spots on the outside. All right, then there's supination and pronation. You guys should be very familiar with that already because we've already talked about it in the lab. If you are supinating, you are carrying a bowl of soup. When you are pronating, you are playing pro basketball. Okay, that's how I read it. All right, supinate to pronate. Supinate to pronate. When you think about it, you put the key in the car. Of course, I don't have any keys to put in cars anymore. I just push buttons. But if you put the key in the car, what do? You have to supinate to get it to turn on. Okay, that's kind of the way to think about things. Then we have flexion. Okay, that's at the hips. And hyperextension, going past 180. Right, going beyond that. Oh, can't do that. Some of you can do that. Pretty much stop. All right, lateral flexion, again at the hips. And right rotation, and then we have rotation at the pivot of the atlantoaxial joint. When you say no, that's C1, turning on C2. Then we have my favorite, protraction and retraction. So protraction and retraction. All right, so protraction, you still twinkle the Thurston Howell the third. You're like, who the heck is Thurston Howell the third? Gilligan's Island? Anybody? Yeah, okay. Thurston Howell the third. All right, so that is to protract the jaw, the mandible, and to retract, pull it back in. Now, watch people eat. I know, really. Look at them eating and see, are they protracting and retracting while they're eating? If they are, man, that's kind of weird. You all do lateral and medial excursion. Not to that extent, but when you're grinding on food, chewing your gum, there she goes. I said it and you just started doing it. I mean, there's a little medial lateral excursion there going on. You're moving the mandible from side to side. Okay? It's useful when you're grinding because of the molars, and you get food in there and you just grind on it. And you start to break it down. All right, then we have flexion and both the radius and the ulnar. Whoops, the ulnar and the radius. All right, so when you do the Queen's wave, there we go. We'll do the Queen's wave, right? So you can all be princesses and queens. All right, and then the abduction and adduction, as we've already mentioned. And guess what? You can do that with your thumb, just your thumb. You can adduct your thumb. We have a muscle for that. It's called the adductor of the thumb. It's called adductor pollicis. We'll see that later. Okay, and you can also oppose. There's that thing that sets us apart from all other groups of animals. Animals. And there is a muscle for that. It's called opponens pollicis. To oppose the thumb to the other fingers. All right. Then, flexion of the ankle. Dorsiflexion means to point your toes skyward. Because remember, we are flat on our feet, but technically, anatomical position, you're in the toe position that a ballet dancer uses. And in that case, you are plantar flexing. Your foot is flexed towards the plantar surface. That is the bottom of your foot. Dorsiflexion means the top of the foot, which is the dorsal surface, has been flexed. So that's dorsiflexion to point your toes up. It is plantar flexion to point your toes down. Bring your toe shoes in. Keep that straight. Anybody? Listen. No, you didn't write that? I should have asked you to do that. Then there's inversion, and yeah, you're all like, oh God, I'm not demonstrating it. Then there's inversion and eversion. Okay? So to walk on the outside of your foot is to invert your foot. So the sole of the foot is inverted towards the midline, towards the inside. And if you walk on the outsides of your feet, then you are everted. So if you're a skier, they teach you how to snow plow. Turn your feet inwards, right? You move your knees towards the center. That's an eversion activity. All right. So those are the movements that I want you to be able to do, to reflect on, to think about. When I say flexion, what does that mean? Decrease the angle. When I say abduct, what does that mean? Take away. Those are the things that you might be asked to do. It's a hilarious day when we take this written exam, because I look around the room and some of you are doing, what am I doing? You know, and you have to think about it. It's kind of, all right, so a little bit about some of the joints, these big major joints that you're going to be having to deal with in your careers later on. I'm not asking structures here. That comes in the lab. But you'll notice that the shoulder, the actual technical term is to call this the glenohumeral joint, because it is the glenoid cavity with the humerus attached to it. So technically, your shoulder is glenohumeral. And then you can see that there are ligaments between some of the bony structures here. So we have, of course, the clavicle to the acromion. So that's acromioclavicular. We have the clavicle to the coracoid. So it's coracoclavicular. We'll be doing some of those structures and ligaments later. Down below here, you can see that there are some tendons that are coming into play. Okay? Supraspinatus, the deltoid muscle. There's going to be the infraspinatus, the subscapularis. All of these that are going to help you do this action. Now, I don't spend a lot of time on the elbow. Elbows don't get damaged that much in terms of athletics. I know they do, but they're not super damaged. unless you're a pitcher, and then it's the ulnar collateral ligament that gets all messed up, and you need what's called Tommy John syndrome, or Tommy John surgery. So the ulnar collateral, the one that is attaching the ulna to the humerus, is torn, and they have to replace it. And there's one special tendon that they use, and if you use your fingers like that and bend your wrist, you may see a tendon that pops up in the middle. And that's called your palmaris longus. They take that ligament and they attach it here at the elbow, because you really don't need that muscle. It doesn't do much. Okay? So baseball players, softball players, Tommy John, you know. Softball players don't typically get Tommy John surgery because they throw underhand. Just the natural motion. People throwing overhand, and volleyball players who are smacking like that, that's not natural. Okay? Quarterbacks ought to be throwing underhand. Mahomes does it all the time. He does. We're good at it, right? But golfers are kind of natural, except when you swing really fast and rotate really hard. And you know, the swimmers with freestyle and butterfly, that's killing your shoulders. So then the hip, yeah, I'm becoming an expert in that. So again, it is a ball and socket, and this we call though coxal joint. That's one name for it. Okay, or the other name is the iliofemoral, because it's the ilium and the femur that are attaching to each other. And so there is a labrum. Oh, she's not here. She had to leave. So there's the labrum that she's tearing. And there's the head, of course, and the little ligament that attaches to fovea capitis. That little depression in the head of the femur. That's what's attaching to it, right there. It's called the round ligament. It attaches into the acetabulum. So, lots of ligaments, again, that are holding this joint together. And then, of course, the most complex and probably the most injured, the knee. Okay? Overall, probably the most injured. I mean, there's a specialist at a clinic in Indianapolis. All they do are knees. So, must be damaged a lot. So lots of structures we've talked a little bit about because of the ligaments that are intracapsular, like the cruciates, and the externals that are the tibial lateral, or collateral, excuse me, and the fibular collateral. Again, those are things you're going to see in lab, introducing right now. All right, as always, there's things that go wrong. Hang on, some of these aren't pretty. So, overall, you could say at any time you have rheumatism if you are experiencing pain in a locomotive tissue. Pain in a locomotive tissue. Now, what do I mean by locomotive? Does that mean bones? If I say locomotive, what do you think? Is a bone a locomotive tissue? No. If I say muscle, yes. If I say tendon, yes. If I say ligament, yes. We say synovial capsule, tissue, membrane, all that stuff. Is that a locomotive tissue? Yes. It's involved in the motion, okay? If it's a synovial joint. So rheumatism is just a very generic term. Okay? Now, there are specialists that are called rheumatologists. They are dealing with pain that may or may not be surgically correctable. Okay, we'll get a little bit more into that in a second. All right, so rheumatism, generic term. Now, strains and sprains sound the same but are not. And I shoot the person who came up with the two names that sound alike, and you got to keep them straight. You'll notice strain is the muscle or the tendon. Okay, the muscle or the tendon. So, it is not that they are completely separated and are completely torn. It could be a partial tear. It could be an overstretch of the muscle or tendon. It is creating issues in motion. So we would call that a strain. Now, I don't know, if I think about it, I see T in strain, I see tendon. That might be a quick and easy way to keep it straight. Okay. And then assuming that you remember muscles attach tendons to bones. So muscle, tendon, that unit. Okay? Now, sprain is in the ligament. Okay, so I'm showing you some ligaments in the ankle. And again, they are graded. A little bit of stretch, maybe a little tear, 1. More tear, 2. 3 is a lot more. 4, it's 1. Okay? Not going to fix on its own kind of a tear. And it's a ligament. Okay? I have no quick and easy way to remember that. If I remember strain is muscle and tendon, then the other one must be the ligaments. Okay? All right. Then we have bursitis or tendonitis. So any tennis players? I can't remember. No? Yeah? Oh, there we go. Tennis elbow like the worst, right? Because look, it looks like a tennis ball. Tennis elbow. So, it's inflammation within the bursa sac or within the tendon sheath. But it is the involvement of an extra synovial sac, something with synovial fluid in it, that is outside of the synovial capsule. So bursa and tendon sheaths are inflamed. Now this poor person up here, it is very likely that's an infection. Okay? I mean, you don't usually get that kind of inflammation without something going on inside. All right, then we have osteoarthritis, wear and tear, and usually associated with age. Okay, so there's a knee. What's wrong with that knee? Louder. No cartilage. Which side? One or both? Right or left? See a gap here? Yeah, do you see a gap there? Do. Okay. No gap. That's my left knee. It's not my left knee, but might as well be. Okay? So it's the wear down of the cartilage to the point where it is becoming bone on bone. Okay? That's typically what we think about. So when is that most painful? In the morning, middle of the day, or at night? First of the day. You haven't been moving it. Start moving it, get the synovial fluid flowing again, and it loosens up. Okay? It's less painful throughout the day. Now, if you overuse it, by the time nighttime rolls around, then you've got swelling, and yeah, it hurts again. Okay? So there's a lateral view of that same ankle, or same knee, and you can see there's no space there. Okay? Then we have rheumatoid arthritis. So this is what a rheumatologist typically deals with the most. Okay, so rheumatologists dealing with that pain in locomotive tissues, they are treating a lot of patients with rheumatoid arthritis. So rheumatoid arthritis differs from osteoarthritis because it is an autoimmune disease. So the person develops antibodies that attack the synovial membrane. Now remember, the synovial membrane is on the inside of the capsule. And there should not be any cells in there, but there could be white blood cells, and they develop an immune reaction to those tissues. And they develop antibodies, which have an immune function, and they cause inflammation. And the synovial membrane begins to break down. They begin to have less and less synovial fluid. Now this is a very, very advanced case. And so the x-rays illustrate what's happening. So you'll notice the very white, bright spots. Okay? That is a destruction of the synovial membrane tissues lack of synovial membrane and fluid, and the bones begin to fuse. The only solution, if it gets to that stage, is to replace every single one of those joints. That's it. That's all you can do. The goal then would be to suppress the immune response so that it does not advance like that. I have a colleague who has rheumatoid arthritis. He is or has at varying times taken chemotherapy drugs, things used for cancer patients, to try and minimize the advancement. All right, then there is gout. Now, we haven't talked about uric acid. Uric acid is a byproduct of protein metabolism. So as you metabolize, as you break down proteins, specifically the amino acids that make up the protein, part of the byproduct of that could be uric acid. Now the name uric, urine? Well, yeah, you get rid of it in your urine. That's what you're supposed to do. But sometimes you have too much of it. And who knows why, but it starts to form crystals inside of the joint capsules. Okay. Now, one of the places that is very frequent for gout, first sign of gout, is in the big toe. The joint capsule of your first phalange of your foot. Why? Why the foot? Why the big toe? Giving you the clues. Uric acid. What does uric sound like? Urine. Where does urine get produced? Oh boy, next semester is going to be a lot of fun. We got to start from ground zero. Where do you make urine? In the liver? Kidneys. And how does the uric acid get to the kidneys? Through blood, circulation. And what's the farthest from the heart? The big toe, your feet. So, sedentary lifestyle, it starts to collect there. Because it starts to crystallize. As it does that, you're not getting it out of it. Okay? Now, why then does this happen? Well, there's a genetic component. There's some lifestyle choices. Smoking always, always, always. Drinking to excess always. But also eating a lot of meat. Lots and lots of meat. So back in the day, 20 years ago or so, there were two diets. The Atkins diet and the South Beach diet, both of which told the people eat lots of meat and very little carbohydrates. And yeah, suddenly there was a little bit of increase in gout. Now once that happens, once you get those crystals in there, you can hear the people going, oh, the weather's going to change. How do you know? Oh, because my gout's flaring up because the pressure changes. They know it's happening. Okay, when you do surgery, that's what it looks like. It's like there's so much chalk, right? Cool. No? Ben? No? Keep that from happening, right? So no sedentary lifestyle. Balance your diet. Don't drink to excess. Don't smoke. I'm saying don't drink, but don't smoke. Okay? There you go. We're done. Why are you sitting there? I mean, you know,